Hello everyone, hello all obstetrician and gynecologists who are preparing for the postgraduate exams. Today I'm going to discuss with you the TOG article of investigation and management of postcoital bleeding, which is very important for both your written exam and OSCE exams. Very common in your clinic, you will find a case present to you with a bleeding during or after sex. So, what could be the possibility? This is what we are going to cover today. So, we will ask ourselves, is it cancer or maybe just a vaginal dryness in a postmenopausal woman, or a trauma, maybe, or a benign condition, or maybe just an infection? So, let's see how is the approach for the investigation and management of this case. Very importantly, okay, you know why this is a concern, as again, we said that the prevalence of the postcoital bleeding in the community range from 0.7 to 9%. That's almost 1 in 10. They have this condition, but the cumulative incidence in a premenopausal woman is 6%. Okay, so remember the number for SBA's questions. In our investigation, we want or we aim to exclude the cervical cancer. However, this is not the most common cause of the postcoital bleeding. Postcoital bleeding can be due to benign condition, simply urogenital atrophy, like in cases of breastfeeding women, postpartum, for example, or cases of postmenopausal. Some conditions very common in our practice, like cervical ectropion or cervical endometriosis or cervical or endometrial polyp. Sometimes it can be a benign vascular tumor of the genital tract, like hemangioma. Other causes, like malignant condition, vulval cancer, vaginal cancer, cervical or endometrial. Vulval reason, like chronic vulval dermatosis, like lichen sclerosis, for example, or genital warts or ulcers, or infections like vulvovaginitis, for example. Okay, especially if there is Cervicitis as well due to chlamydia or gonorrhea infection. Endometritis sometimes also in the presence of a copper coil IUCD can lead to a postcoital bleeding. Other causes like trauma or bleeding disorders or the presence of foreign body or pregnancy-related or FGM or even sexual abuse. So here comes the importance of the history and examination, right? First of all, the history is important, okay, during your assessment of the case. So you will be able, to determine what differential diagnosis or what are the possibilities that you are searching for, right? It will minimize your options. History that include the patient age, duration and frequency of amount of bleeding. So my friends, of OSCE Part 3 MRCOG exam or MRCPI exam or your board exam, please listen carefully when you take history. You need to start with history of the present complaint or the present illness, duration, frequency, and amount of bleeding. Cycle history, menstrual history is very important. So we will start with the present complaint and then come to the next, and the next is the related symptoms. A woman had a bleeding, I need to know the cycle. If there is any abnormality in the pattern of cycle, when was her last menstrual cycle? Then I will go to the general gynecology history, like the presence of other gynecological symptoms, like vaginal discharge, pain, or dyspareunia. I need to ask also about contraceptive history and use of any methods. I need to check the cervical smear history, right? That's very important. if the woman is updated with her smears and what was the last result, if she had any previous treatment, like she had a colposcopy or a similar condition before, sexual history, that's very important, including history of STIs, sexually shared infection. Then I will go to the rest of the history. So first of all, I need to ask myself, where am I? I am in the gynecology clinic. What is the case? Postcoital bleeding. So I will start from the presenting complaint, then to the related history, okay, and the histories that will serve my differential diagnosis. Then I go to the other history like sexual history, include any previous history of sexually transmitted disease, as we said, medical, surgical, any bleeding disorders, any medications, especially if she is on anticoagulant. Then we ask about other risk factors, maybe like smoking or abuse. Okay, so this is the importance of history taking in a case of postcoital bleeding, which is an OSCE exam case. The sexual risk assessment also can be involved in a woman aged 25 years or younger, okay, or in a woman with higher prevalence of chlamydia. So all women should be screened for domestic and sexual abuse because of the trauma in the genital tract can result in a postcoital bleeding. I would remember HARC. HARC is abbreviation for humiliation, afraid, rape, or kick. Okay, so I'll ask about any history of violence in the last years that may suggest that this woman is a victim of sexual abuse. Okay, so not all the cases are that scenario. Not all the cases, they have a problem like that. So let's see, okay, if a case presented to her doctor, especially the primary care doctor, and we here speak about mainly the UK system, or if she comes to you in your clinic in any place in the world, okay, so I have to ask myself if this woman had updated cervical smear or not. Okay, why? Because again, I need to remember in my investigation and in my examination, I need to exclude the cancer. Okay, while I'm doing that, I will check other differential diagnosis and I'll reach to the correct management. Okay, so let's have a look to this algorithm, which I recommend that you print this out, all my friends, especially in the written exam, not only OSCE. Okay, you need to look to this algorithm. I always advise you that you have your algorithm printed out, right? So let's check the diagnostic pathway for investigation of postcoital bleeding, right? Okay, so at first a woman presents to you with a postcoital bleeding. What shall you do? The first thing to do, and it should be the initial next step or the next step in the management, is history and physical examination. Well done. So the history and the clinical examination, as per we covered in the history, okay, you analyze the complaint carefully, other possibilities or differential diagnosis, so it will help you or guide you to what is the next step in action. Okay, so in the next step would be a microbiology swab. I need to rule out infections, okay, and if it comes positive, this will prompt treatment, okay, and refer into the gum clinic for contact tracing if the woman had a sexually transmitted infection, like for example, chlamydia or gonorrhea. Okay, so this is one possibility covered by the microbiology swab. The second possibility that I need to check if the woman had her cervical smear test and she missed the last one, it is overdue. Okay, so I need to collect, the smear. That's very important step at the clinic. It can be done in the UK at the GB clinic, not only the gynecology clinic, but let's assume it comes to you in the exam and he will guide you to choose this option by mentioning that the woman, she is not updated with hair smear. So what is the next step in action? Next step will be cervical smear. Okay, why? Because it's abnormal. I need to refer this patient to the colposcopy as per the cervical screening guideline. How about if during my examination, my speculum examination, I saw a clinically abnormal cervix? Any clinically abnormal cervix or suspicious cervix, prompt referral to colposcopy. Yes, well done. It's an old question. It's one of the classic questions that comes in the gynecology module for the MRCOG and MRCPI and board exams. Whenever there is abnormal cervix, go for colposcopy, please. Okay? Okay. How about if he said that the cervix is normal, but it's a persistent postcoital bleeding, okay? Or coexist interministral bleeding. So the woman, she not only having a postcoital, but she have post-complaint interministral bleeding, which is not related to the sexual activity, okay? Or the postcoital bleeding is persistent despite of previous treatment or something. So here I will consider transvaginal ultrasound plus or minus PIPL biopsy. And remember, PIPL is used as an investigation that's used in the which population? In the postmenopausal. Well done. Plus or minus hysteroscopy according to the case. So which one shall I choose in exam? Please, you will choose based on the... Yes, you are correct, based on the history, right? So either TVS or biopsy, bipipal or hysteroscopy, this is the, next investigation in action for a case of postcoital bleeding, and it's persistent or with associated with interministral bleeding, okay? So it's not like one step, two steps, second, three steps, and we will go stepwise approach. No, it's based on the case. Okay, my friends, right? Okay. Causes and management of postcoital bleeding. This is another part, okay, that we are going to go through it. Here, we will take individualized causes and have a spotlight on it. Okay, so one of the causes, the common causes, that the cervical ectropion. Cervical ectropion is considered as a normal physiological finding, and cervical eversion results in a friable, mucus-secreting glandular epithelium of the endocervix being exposed on the ectocervix. It classically appears as red disc around the external cervical os. Take care of the examination finding given to you in the cases. Red disc around the external cervical os. It's often seen after menarche during pregnancy and in women taking the combined oral contraceptive pills, arising as a result of cervical remodeling in response to estrogen, so estrogen-related physiological changes. Women with cervical ectopy may present with increased mucopurulent vaginal discharge and a postcoital bleeding, or may be asymptomatic at all, no symptoms seen. On speculum examination, cervical ectropion may cause contact bleeding, making it difficult to exclude significant disease without colposcopy referral. Okay, so a woman, he give you her investigation finding, the examination finding, and he said that it's a red disc around the external cervical os. You believe that this is a cervical ectropion, but also during the examination, you find that there is a contact bleeding, bleeds on touch, or a friable cervix. What is the action again? Shall I choose simple treatment of the cervical ectropion, or shall I choose referral to the colposcopy? Yes, excellent, my dear candidate. It's of course a colposcopy referral. Okay, so apart from the investigation and the colposcopy referral for the cases with a friable or bleeding cervix, what is the treatment option? Treatment, women should be informed regarding the physiological nature of the condition. Given this reassurance, the patient may decide not to have any further treatment. Or if appropriate, so a woman comes to you in an exam she is on a COC, change the combined contraceptive to the progesterone only may resolve her symptoms. Okay, so it may come in the exam, like an OSCE case, for example, and you give opinion to the lady. You have to give the woman options. Remember, respecting the patient autonomy and having informed discussion with her. So that means you need to discuss options of treatment. So option number one is reassurance. Maybe she chooses to do nothing. Or option two, if she is simply on a combined contraceptive pill, then maybe switching to a progesterone only will resolve her problem. Women with persistent or troublesome symptoms can be offered the cryocautery or diathermy to the cervix. Okay, so if the woman insists that, or the woman explains to you that these symptoms are persistent or really affect the quality of her life, then offer active treatment by cryocautery or a diathermy to the cervix. Okay. Okay. The potential side effect to the treatment, which you need to cover in OSCE stations, is vaginal discharge, that it will be obvious, okay, and it will persist till the healing, is complete. So it's very important that you warn the lady about these symptoms. Where and when? Cryocautery should be performed in the gynecology clinic if the woman has had regular and negative cervical screening. So I need to confirm first. Remember, stepwise approach in the management. Collect sample for STI screening. If the woman is not updated with her smear, then cervical smear should be done before you decide on a treatment, right, like a cryocautery. If you are in doubt, cervical biopsy should be performed and the treatment delayed until the histology is known. Remember, safety is first, always first. Okay, how about the management of cervical polyp? Cervical polyps is another cause that comes in under the postcoital bleeding. It can also cause intermenstrual bleeding. So cervical polyps are usually asymptomatic and found incidentally on the speculum examination. But if, let's say, you are examining a lady and you find a pedunculated, fleshy, lobular structure, it can arise from the endocervical canal or the ectocervix or from the endometrial polyp and its prolapse through the cervical canal. These should be friable and easy bleed on touch. So this is a description or the gross picture of the cervical polyp. Most frequently, this is present in a perimenopausal and a postmenopausal woman. Symptomatic polyp and cases with coexisting abnormal cervical cytology should be removed and sent for histology to exclude any malignancy, right? Small polyp should be grasped at its base using polyp forceps and twisted up. Hemostasis can usually be achieved with silver nitrate. So this is for the management of small polyp. A polyp forceps twisted off and hemostasis by silver nitrate. Large or broad-based polyp. This may require removal with a loop diathermy at colposcopy. Okay, so options will be based on the size of polyp. Smaller one in the clinic, polyp forceps, apply silver nitrate. Larger one, okay, colposcopy, and it will require loop diathermy at the colposcopy. A very important number for the single best answer questions here is endometrial abnormality has been reported in up to 55%, more than half, of postmenopausal women with cervical polyp. That's advocate that the woman should be offered hysteroscopy and the endometrial sampling in addition to avulsion of the polyp. So the management will be a hysteroscopy, polypectomy, and endometrium sampling, okay? So that's very important combination of the management, of the correct management if a polyp present in a postmenopausal woman due to the high rate of endometrial abnormality. Risk of dysplasia or malignancy in a cervical polyp is estimated to be 0.0 to 1.7, which is actually make you think of asymptomatic women should have or can have the conservative management in this case because of the low risk. Okay, so my dear friends, difference between endometrial polyp and cervical polyp in the management is very important, especially if he mentioned for a reason that the woman is asymptomatic in a cervical polyp. You may think or counsel her about conservative. Okay, so let's see the cervicitis, endometritis, and pelvic inflammatory disease. Here, he started with a very common single best answer question as well that came before in the recall about the chlamydia is considered to be the most common bacterial STI and estimated to affect up to 7% of women under the age of 25, which is high prevalence, of course. Risk factor for infection include age under 25, new sexual partner, more than one sexual partner in the preceding year, and inconsistent use of barrier contraception. First-line treatment for a woman with suspected or confirmed chlamydial infection is azithromycin, 1 gram oral as a single dose, followed by 500 mg daily for 2 days. So means that the woman will receive total of 2 grams of azithromycin divided on 3 days. 1 gram, 500 mg, 500 mg. Or the alternative is doxycycline, 100 mg twice per day for 7 days. The single dose treatments are associated with better compliance with the patient. So that's why it's very common that we prescribe for the patient the azithromycin rather than the doxycycline. Women should be advised to abstain from sexual intercourse until treatment is complete and should be referred to a local sexual health service for screening for other STI and partner notification. Test of cure is not usually required unless there is a complication or a compliance disorder or a recurrence, of course, of the disease or the patient is pregnant. It is the same as the PASH guideline of the chlamydia infection advice. Less frequently, gonorrhea may be the cause of postcoital bleeding. That means, my friends, sometimes you find a question, postcoital bleeding associated with STI, what is the common organism? And he give you both chlamydia and gonorrhea. Which one you will go for? Yes, correctly, you will go for the chlamydia first, of course, because the chlamydia is the commonest bacterial. However, postcoital bleeding can happen with the gonorrhea, but less commonly. So the first-line treatment of uncomplicated gonorrhea is ceftriaxone, 1 gram intramuscular as a single dose. Remember, again, that the doses of the treatment of ceftriaxone has increased over the past years. It started in the past, in the practice, we used to give 250, then we give 500. Now we give 1 gram, okay, of the ceftriaxone IM as a single dose. Test of cure is advised for all patients confirmed to have a gonorrhea because of the increasing prevalence of antibiotic resistant strain. Again, this is the same as the PASH guideline, right, of the gonorrhea, right? So here you have revised chlamydia and you have revised the gonorrhea in few lines only. Okay, well done, my friends. Remember, the test of cure is indicated in all cases of gonorrhea, but not all the cases in chlamydia. Okay? Okay, my friends, thank you. Let's move to the next. Recommended antibiotic regimen for the treatment of pelvic inflammatory disease. Okay, so we again with another topic of the PID. In the PID, you remember that the treatment will be continued for 14 days. Those are basic management. You remember also that there is outpatient regimen, there is inpatient regimen, okay? And here we start with the outpatient, which is in the cases of mild to moderate PID, inpatient for the severe cases, complicated cases, or very high temperature. Outpatient, intramuscular ceftriaxone, the first line antibiotic regimen, 1 gram as a single dose. This is to cover which infection? This is to cover gonorrhea, remember. Plus oral doxycycline, 100 mg twice per day for 14 days. So you are covering chlamydia and other organisms. Plus oral metronidazole, it's 400 mg twice per day for also 14 days. Another regimen for the outpatient is oral ofloxacin, 400 mg daily for 14 days, or oral metronidazole oral metronidazole for 100 mg twice daily for 14 days. So a combination between ofloxacin and metronidazole. Or moxifloxacin, and remember when to offer the moxifloxacin in areas where the prevalence of Mycoplasma genitalium infection is higher. So mycoplasma with the moxifloxacin. This will be given as 400 mg once per day for 14 days. This is a very good combination for your eMRCOG questions and also for your patient in your clinic. Inpatient to start with intravenous, then switch to oral after 24 hours if the patient had a clinical improvement. This is a rule. Oral also will be continued for how many days? For 14 days. Well done. Intravenous ceftriaxone, 2 gram daily. Intravenous or oral doxycycline, twice per day, 100 gram, until 24 hours after clinical improvement. Followed by oral doxycycline, twice per day for 14 days, plus oral metronidazole twice per day for 14 days, and take care of the doses. Another alternative is intravenous clindamycin, 900 mg 3 times per day, plus intravenous gentamicin, 2 mg per kg loading dose, followed by 1.5 mg per kg 3 times per day until 24 hours after clinical improvement. Remember, my friends, that if you give gentamicin to a patient, take care of the renal function, please, and gentamicin level. So, what is the oral regimen to continue with? Of course, if you started clindamycin, please continue with oral clindamycin. That would be 450 mg 4 times per day, or oral doxycycline 100 mg twice per day plus metronidazole for 14 days. Okay, my friends. Ofloxacin and moxifloxacin should be avoided in high risk of gonococcal pelvic inflammatory disease due to the higher rate of resistance, but it's very useful if you have mycoplasma. Okay, now moving to the scary cancer, cervical cancer. The prevalence of cervical intraepithelial neoplasia, CIN, and cancer among women with postcoital bleeding is estimated to be 3 to 18%. HPV 16 and HPV 18 are the commonest pathogenic subtype, accounting for over than 70% of cervical cancer. It is estimated that 70% of women will contract HPV in their lifetime. Okay, so the commonest pathogen is a very common single breast cancer question, okay? And it causes also over than 70% of cervical cancer, another common question, okay? And very important that the current immunization program comprises of the 2 doses of the Gardasil, the quadrivalent HPV vaccine that will protect against HPV sex 11, 16, and 18. The program target age 12 to 13 girls, but now extended to include boys as well in the same age. Vulval and vaginal lesion can be reason of the postcoital bleeding. So the urogenital atrophy result from estrogen deficiency, the commonest in postmenopausal women. Is typically present with vulvovaginal dryness and irritation, decreased lubrication, superficial dyspareunia, and occasionally postcoital bleeding secondary to trauma during the intercourse. So start by, again, dryness, irritation, sometimes mild itching, decreased lubrication, superficial dyspareunia. The examination finding is important because it will give you a clue of the diagnosis in cases which include pale and dry vaginal mucosa with contact bleeding on the vaginal wall or cervix. Of course, the treatment would start with lubricant, okay, something to moist the skin, and topical estrogen. Topical estrogen is the main, treatment that we will offer to improve the vaginal dryness in a postmenopausal woman. Also, there is dihydroepiandrosterone, the DHEA, or the laser treatment as well. Okay, vulval biopsy should be considered if you think that there is a pigmented lesion or ulcerated lesion or erosion, okay, or the patient failed to respond to the initial treatment after diagnosis. Remember, information about the lichen sclerosis that is associated with 4 to 6.7% risk of developing squamous cell carcinoma of the vulva that will require annual review. Lesion should be biopsied rather than excised and should include area of epithelium where there is a transition from normal to abnormal tissue. If the vulval cancer is strongly suspected on examination, then urgent referral to tertiary cancer center should not be delayed while awaiting the biopsy result. Okay, so based on the suspicion of cancer, you will prompt the referral, urgent referral, don't await the biopsy result. Another cause of postcoital bleeding is the vaginal interepithelial neoplasia. And vaginal cancer are usually asymptomatic, but may be, the woman reported spotting following intercourse or unusual vaginal discharge. Women with suspected VAIN or vaginal cancer should be urgently referred to colposcopy for further assessment and biopsy. Please take care, referral also for colposcopy. Okay. So what is the buzzwords or the keywords for you for the VAIN? It's white or red mucosal plaques. While in vaginal cancer, it will be persistent ulcerated lesion, usually on the posterior aspect of the upper third of the vagina. Okay, so be careful of the examination finding, please. In cases of the traumatic bleeding, then surgical repair is a standard of care. So my friends, this is all what I can say about the very important TOG article of the postcoital bleeding, which is a recent one as well, and it can be part of your exam very soon. Good luck for your exam, and it was my pleasure to be with you today. This is me, Dr. Rabah from the eMRCOG team. Thank you.